Okay, it seems to have stopped accumulating participants. Good morning, everyone, or a good afternoon, or maybe even good evening. I'm Pim Brouwers. I'm a science officer from the National Institute of Mental Health here in Bethesda, Maryland, and I'll be the facilitator of this session on the MADIVA hub. And we're very fortunate to have Daniel Deritu, if I pronounce that
Yes.
correctly, to start the presentation by telling us about the hub. So the floor is yours. I think that you have a chance. Yeah, okay, perfect. You can share your screen. Great.
Yeah, thank you so much, Pim. It's a pleasure. My name is Daniel Derito. I'm a data scientist working for the MADIVA Research Hub. And I'll be here to present quite a number of items and responsibilities that we are working on in MADIVA. So MADIVA stands for Multimorbidity in Africa, Digital Innovation, Visualization and Application. It's a research hub that has quite a number of partners. So I'll be taking us through the partners, the aims, the sites, the structure and composition, the projects and activities. Multimorbidity is the coexistence of two or more chronic conditions like hypertension, diabetes, heart disease, angina, and the like. So the broad aim of the research hub is to develop machine learning techniques to generate insight into the problem of multimorbidity. We know it's such a big issue that is continuing to grow and to plague different healthcare systems. So we are looking at that. So in terms of the specific objectives of the research hub is first and foremost is to understand the problem of multimorbidity in Africa and how public health interventions affect it. We are also pioneering the use of polygenic risk scores and developing public precision medicine with respect to multimorbidity. We are also endeavoring to understand how data science can support sub-county health management teams, and as well as developing data visualization websites and understanding the data. Currently, we are working with secondary data, as I'm going to be showing you later on. So we are combining, we are doing data integration and harmonization, and I'll also be explaining that. The Research Hub is also developing novel machine learning techniques also to understand the problem of multimorbidity. Going to my next slide, it shows the partners that we work with. As a research hub, we have the University of Witwatersrand, Johannesburg. Then we have the African Population and Health Research Center, headquartered in Nairobi. We have the South African Population Research Infrastructure Network, Vanderbilt University Medical Center. We have IBM, that is the International Business Machines, and DSI Africa. The Research Hub has 4 principal investigators. Professor Scott Hazelhurst from Wits University. We have Professor Michelle Ramsey, the director of Sydney Brenner Institute of Molecular Biology. We have the director of APHRC, Dr. Catherine Chobutungi, and Professor Stephen Tolman of Medical Research Council, Agincourt. Currently, we are working with 2 sites, one in Nairobi, actually 2, sorry, in Nairobi, one known as Korogocho, and the other one is called Viwandani. These are informal settlements in the city. Then we also have Agincourt in South Africa, which is a peri-urban setting. And on the right-hand side, sorry, we have one of the pictures of one of the urban settlements in Korogocho and Agincourt in South Africa. This is a structure of the MADIVA Research Hub. We have the leadership and administrative core. We have the data management and analysis core. Basically, what you are seeing on the screen, these are teams that are charged with different responsibilities. So we also have another Project 1 team. I'll be explaining what these teams work on. And then Project 2, and also the training core, which is on the far right-hand corner. The data management and analysis core is charged with data harmonization and integration. It's also charged with quality management of that data and also building the capacity with respect to data management. On the screen is the structure of the data sets that you are working on. In both sites, that is Nairobi and Agincourt in South Africa, the data sets we are working on are built upon longitudinal demographic health surveillance systems. So in Agincourt, the longitudinal surveillance system has been collecting data from 20,000 households, constituting 117,000 individuals, spanning an area of 31 villages. Where in Nairobi, the longitudinal platform has been collecting data from 33,000 households, 88,900 individuals. Data is usually collected 3 times per year in Nairobi, but collected annually in Agincourt. So using this, you can actually see that we are working with quite a massive data set. Then built upon these longitudinal surveillance systems, we have other nested studies, projects that collect data from these sites, one of which is verbal autopsy, which registers any death occurring in those study sites. So in Agincourt, the registration is at 93%, and this data is composed of data that has been collected since the year 1992 up to 2020. In Nairobi, it's at 85%, and data has been collected since the year 2002 up to 2020. If I'm fast, you can tell me. Then we also have other non-communicable disease surveys that have also been done in both sites. In Agincourt, we have one that was done in 2003, 2007, 2014, 2015, 2018, and 2020, and it targeted between 2,000 and 5,000 participants. In Nairobi, it was done 4 times in 2008, 2012, 2014, and 2020. It also targeted between 2,000 and 5,000 participants. The additional 2 studies that were done only in South Africa, one is called the ACT study, the other one is called the HALSI study, that is Health and Aging in Africa, longitudinal studies of an intent community. The years when those were done, we have the year 2018 to 2019, and the other one is 2015 to 2019, and it focused on 5,059 adults aged between 40 years and above. There is another study that was also done in both sites. It's called the AWIGEN study. In full, it's the Africa VITS in-depth study of genomic and environmental factor study. It was done in the years 2015, 2016, and 2020, 2021. And it actually happened in both sites. On one side, that is Agincourt, it focused on 2,500 individuals where cardiometabolic data, genomics data was collected for adults aged between 40 and 70 years. In Nairobi, it focused on adults aged between 40 and 60, and it was collected from 2,100 individuals. Another quite interesting activity that has been going on for quite a number of years, there is additional data for these respondents that is usually collected from health facilities. In Agincourt, this work began in the year 2014, where their illnesses, clinic visits, and every data that is collected at the health facility for these patients who can be linked to the longitudinal surveys has been collected. And in Nairobi, that work began recently, and we hope it will continue because this exercise is really supplementing the data that we already have. Going to, that is actually one team, the data management and analysis team. Going on to the next team, it's referred to as the Project 1 team. This team is charged with building dashboards, clinic and research dashboards, first and foremost to help the clinic management and the healthcare practitioners have an overview, know the kind of patients that they are dealing with, the chronic conditions that they have. And this is actually built upon the data that is being collected at the health facility. And what is quite interesting, they are developing clinic and research dashboards, not alone. but together with the different stakeholders. We have the health department, we have the Ministry of Health in Kenya, and this team has been building dashboards and having stakeholder engagements to be able to gather requirements and also to get feedback of what is being developed. So we hope that at the end of the day, we are going to have very high quality products in form of clinic dashboards as well as research dashboards. This team is also charged with setting up the clinic link system. Earlier on, I had indicated that there is work that is happening at the clinic health facilities where people from the sites, the study sites, when they visit clinic health facilities, the information is collected, and now that information can now be merged with the population level data. And from a researcher's perspective, you can be able to look at the trajectory, how this patient has been falling sick, the kind of visits they've been making and to which health facilities. And through that, we can be able to learn more about multimorbidity. So the team is dealing with the clinic link system, which is a data linkage system. The team is also using machine learning to be able to determine the causes of death. I had indicated there is a study that has been collecting verbal autopsy data, or that has been registering the deaths that have been occurring at the health facility. So we have machine learning models that are currently being worked on that are helping to determine the causes of death. The team is also costing multimorbidity from a healthcare practitioner's point of view, as well as a patient's point of view. The amount of money they spend as they continue to seek healthcare in different health facilities, the kind of medication they buy. Yeah, so all this is being costed by this team, the Project One team. Yeah, I hope we are together and I'm clear. Going on to the Project Two team, this team is also continuing to develop prediction models, machine learning models, and they are using the data that is being worked on by the data management and analysis core to actually build risk profiles for the different patients. And this will enable somebody, when they visit the healthcare facility, a clinician can be able to tell them that based on the kind of lifestyle they are living, or based on their history, or based on their of the data that has been collected, there is a possibility of them developing multimorbidity. So that is the work of this Project Two team that is working on the precision medicine. And this one is actually being fueled by the data. All this work is dependent on the data. Data is able to actually give us the risk factors that make people to develop multimorbidity. And through that, different interventions can actually be tailor-made. Evaluations, implementations, and interventions can be developed to help people lead better lives. The team is also working on polygenic risk scores. I had indicated earlier that there is one study through which we are able to collect genomic data, and that data is actually helping in developing polygenic risk scores. The last team that I'll deal with today, I hope I'm still within time, is a training core. This team is charged with the management of the seed grants and pilot projects. Actually, you as the audience today, you can be able to leverage on this. You can be able to actually apply for seed grants, and you can test out some of the ideas that you have using a real setup, using real-time data. This team also manages training grants. They're able to also identify our training needs as a research hub, and they get the necessary resources to train us. Yeah, they also conduct training, workshops, and mentorship. Otherwise, I've come to the end of my presentation. To get more information about the MADIVA Research Hub, you can actually go to this website, www.madiva.africa, and you'll get all the information that you'd need about MADIVA. Thank you so much. Yeah, I've come to the end of my presentation. I'll be happy to receive any questions. Thank you, and over.
Thank you, Daniel. Please can we hold the questions until the end of the presentations? If you have a question right now and you want to prepare Daniel for it, you can put it in the chat.
Thank you so much. Yeah.
Okay, so Joseph, are you ready to start your presentation?
Yes, I think I'm ready.
Okay, so can you please, I think you have your presentation recorded, so can you share your screen and start that, please?
Thank you so much. Are you able to see my presentation?
Not yet. I just see your screen, but it's not a presentation. It's just a slide.
Oh. Okay. Are you able to see it now?
You're still starting to start screen sharing. It isn't sharing yet. I see the notification that it will start, but
I'm not sure what is happening because I had shared my entire screen.
okay, hold on a second. Let me see. Okay, let me see whether I can get our tech people to help us here. Okay, I just asked the otherwise, Joseph, are you able to actually present using the slides? Because I do see the slides.
Sorry, say it again.
Can you do the presentation live? Because I do see the slides.
Or you're able to see my slides from your side?
Currently not, but previously yes. And I do have your slides. I could also potentially run your slides.
Ah, okay. No, that should be fine as well.
So can you put up your slides again? Because that did work.
Hi, Pim. This is Amit. I'm also in the room, and I do have the slides. I can share on my end if Joseph, if you have any problems.
Yeah, I think I've got problems here. As if you're not able to see what I'm sharing, then
Okay.
Joseph, I can share your slides, but would you mind just telling me when to advance? Or Pim, would you like to, or would you like me to help with
I
this?
don't know whether you need to be on others. I think I have them too. Let me see where.
Yeah, I think the folder only had the slides. It didn't have the recording. So I think if you're able to share the slides, that works, or I can also do it on my end.
Let me see how I can get these to full screen.
Do you see the slideshow button on the upper right?
Okay, yeah, I do. Okay, I got it. Okay, fine. Let me now see how I can get to my. Okay, let's see whether this works. Share screen, where is the one that I want?
Yeah, Pim, it's showing up really nicely. You just have to click that slide. There you go. Yes.
Okay, how do you go back on this stuff? Because I'm too far. Okay, ready to go?
all right. Thank you very much. My name is Joseph Toyama. I'm attached to the University of Limpopo-based Dimamo Population Health Research Center. The title of my presentation is Overcoming Data Silos and Integration Complexity. So the Dimamo HDSS maintains a collection of data sources consisting of numerous data sets which were acquired through various methods. And the diversity of data sets now present a major hurdle due to lack of standardized identifiers. That really complicates cross-source participation identification, reducing the effectiveness of research efforts aimed at assessing health trends from many sources. The main aim of this pilot project is to investigate the cases of multimorbidity within our surveillance area to draw some conclusion and interventional strategies should there be a need. But it is more difficult to arrive at a more accurate conclusion using diverse data set with non-standardized identifiers. Hence, that is actually highlighting the need for linking and consolidation of data records into a single source of truth. Now, listed here are the data sets collected from various projects or sub-projects, and we considered these for record linkage and integration. So the first project, for example, health and demographic surveillance system with a population of over 100,000, is the main project covering the entire surveillance area, with the rest of studies or sub-projects targeting specific populations within or subpopulation within our surveillance area. Now, next on the data linkage. Please, next. Thank you. So this here looks at data linkage, what exactly data linkage is, and the problems associated with unlinked data sources. Now, data linkage refers to the process of establishing the association amongst diverse data sources, and that facilitate comprehensive data integration for holistic data analysis, thus simplifying the investigation and modeling of the phenomenon. Of course, there are a number of problems associated with unlinked data sources. For example, unlinked data source has a lot of data quality problems, such as your inconsistency, incompleteness, obsolescence, and sorry, there is a repetition there, that should be improperness. The multitude of issues of bias as a result of due to erroneous results, and that will also lead to decline in studies credibility. Lack of common identifiers results in data impracticality as well as the imprecision. Next. So this slide presents the project map, the project roadmap, with a step 1 showing high-level data integration process using various tools. For example, we have used our in-house built C# Windows application for record linkage, and we developed SQL pattern matching algorithm to allow us to match the data, or to allow us to match the data based on the generated score. And we also used the Pentao data integration tool to combine or generate data streams from different data sources into our HDSS integrated database. Now, that's basically shown on the step number 2. So step number 2 looked at the integration of linked data into a single data source and building the analytical database from which data analysis can actually be performed. Now, the step number 3 focused on drawing the insight from the data from various analytics. So we thought it's important for us to look into 3 different types of analytics, where we're looking at the descriptive data analytics. With the descriptive data analytics, it helps us understand exactly what happened. And this question will actually lead to even more questions as to what will really happen into the future, how will it happen, and why will it happen. Now, in that case, we will actually be performing the predictive data analytics. And lastly, we have got prescriptive analytics, which is actually proposing an action plan, asking a question such as what should actually be done. And this would actually call for some interventional strategies once we find the solutions, the answers to this particular question. Next slide. Now, this is how we performed record linkage. On the left is an interface developed or the interface of an application developed using C# programming language. So this interface runs an SQL pattern matching algorithm to match the records based on the highest score. Of course, that is actually subject to the telephonic verification. So once we have got the score generated, we call the participant to verify the records. And on the right is SQL function that was used to generate the score. It takes two input streams and returns the score or the similarity index. So the scores are actually ranging between 1 and 35, with 1 to 25 being the lower score, and 26 to 35 a higher score. So these are basically it's a probabilistic algorithm saying the higher score means the similarity or the likelihood of similarity between two input strings. Next. So we link the data across these 5 data sources using personal details, ID number, and phone numbers. And as you can see here, the data from Awigen had the lowest linkage results of 78%, meaning that we had about 22% of the records not successfully linking. And that is particularly because some of the participants were actually coming out of the surveillance area. So, but other studies, because the samples were generated within the surveillance area, we managed to have every single data set linked correctly. Next. Now, there are potential benefits. The potential benefit of our project, or what we are doing, or what we are the processes that we are actually following here, is we have got the streamlined workflow, faster decision making, as well as improved analysis. So for streamlined workflow, efficient data flow and integration, and we enhance data quality and completeness, as well as the cost efficiency. In terms of faster decision making, then we automated our data streams to ensure real-time data synchronization and resource optimization. Now, with regard to improved analysis, this will actually allow us to have enhanced visualization and insight, improved public health outcomes, enhanced research and innovation, as well as interdisciplinary collaboration, especially that the data that we are, due to the diverse nature of the data that we are putting together or we are integrating. Next. The call for collaborations is actually on the development of machine learning algorithms to illuminate some challenges associated with multimorbidity, and also in conducting research tailored to dealing with multimorbidity within our surveillance area. That will be the end of my presentation, and thank you so much for listening.
Thank you, Joseph. That was great. And thanks for doing this live while you thought that it was going to be recorded. Went perfectly. So thanks very much. So now the session is open for questions. I think everyone can unmute themselves. Probably to make it the easiest way to go is if you have a question, can you raise your hand so I can, which is one of the tabs on the bottom, so that I know who can start. So if I can take the prerogative as the facilitator. Daniel, it was really interesting to see that you also had a significant amount of training and potential training webinars and so forth. Is there a way, besides just going to your website, that people can be made aware if they want to of webinars or other activities that you have with respect to training or for further explanation of your hub that they can reach out to?
Thank you so much. Yeah, I'm not alone in this presentation from MADIVA, but I think one of the greatest opportunities that as a research hub we have is maybe opportunities for seed grants or seed projects, because that one can actually give people an opportunity to test out their ideas. Yeah, so I think that's why I was actually directing people to our website, because there they can actually get all the information they need. They can reach out to the different contacts, including the principal investigators. And even if it's personal questions, they can always reach out to. The other opportunities that maybe as a research hub we have, sometimes we've had job opportunities. So for people who would like to come join our team, I think there are opportunities, and I believe my colleagues can actually attest to that. Then there are also training opportunities. Sometimes we usually work together with DSI. So whenever you are sending out the newsletters, when we have opportunities for training, we are also involved in those. Yeah, I hope I've answered well. Thank you.
Yeah, no, that's great. And so within DSI Africa, there's also a number of training hubs. Are you linked to any of these?
We are basically members of DSI. We like the DSI consortium, so we are involved actually. Yeah, and maybe I don't know whether Kerry can mention something to do with that. With your permission, I have my colleague called Kerry.
Hi, Kerry Glover. Okay, great.
Yeah.
Hi. I just wanted to clarify the question. Was it that are we involved with any of the training hubs?
Right.
Not officially. We have a core within our project that is a training capacity and development core. And what we do is we liaise with DSI Africa when we do offer training, or when training comes through DSI, we disseminate that within MADIVA as well. So that is our sort of connection to training. We go through DSI.
Great.
There are two questions that had been raised. I don't know whether I respond to them.
Yeah, please.
Briefly.
Yeah, go ahead.
Yeah, I think there are 4 questions. I tried to answer them via chat. So one question was, how do you deal with individuals moving from one health facility to another? And I think the issue here was, how do you link their data? So we have an algorithm or an application that really helps us to be able to capture somebody. You can always know this is this other person using probabilistic data linkage. It's an algorithm, a data science algorithm that can really help you to pick or rather to pick an individual and bring their records together. So that is how we deal with it. Because you can never control, you can never tell people don't go to health facility B, just go to health. No, you cannot control that. So they're able to visit the different health facilities. In Agincourt, we are working with 8 health facilities and 5 health facilities in Nairobi. But people also go out of those health facilities to seek healthcare out there. Yeah, but whenever we have the opportunity, we bring in their data, yeah, together. So the other one was the impact of the presented project. We are trying to help in the management of multimorbidity. Yeah, we help the clinician to be able to know people who are at greater risk of developing multimorbidity. Secondly, the way most of the healthcare setting is, people are usually treated in isolation. You go today for a hypertension clinic, then tomorrow maybe there is a diabetes clinic. But when you're looking at issues as multimorbidity, you're able to manage all the conditions together. Yeah, and also provide, or rather avoid the issues that come with polypharmacy, where you've given a patient these drugs and tomorrow they are given other drugs from another health facility, and those drugs react in their bodies through what we call polypharmacy. So when we help to manage multimorbidity, we can be able to, there was an issue that was asked about understanding multimorbidity, and this one is from 2 perspectives. It is important for researchers to understand multimorbidity. What does it entail? The prevalence, the risk factors. Do we have a population that is more at risk of multimorbidity than? So when you get all this information, when you go down into the publications and understand the issue of multimorbidity, as a researcher, you're able to advise the policymakers, the government bodies in the right way, so that even when they are formulating policies, they formulate them from a point of knowledge. Then it is also important for clinicians to understand multimorbidity. Nowadays, there is no need of you managing a condition in isolation. It is important as clinicians, the doctors, to understand that when somebody has multimorbidity, when they have multiple conditions, it is now better to manage all the conditions together, so that where there is no need of giving them so many drugs, you just give them the necessary drugs that will be helpful to their bodies. Yeah, I think those are the questions that I captured. Over to you. Thank you.
Great. Thank you, Daniel. Any other questions? Okay. Well, then maybe I should give you all a few minutes to take a break, and we'll see you all back in the general room, where you can go by clicking the leave room in the lower right-hand corner. Thank you all for participating in this session on MADIVA, and thank you, Daniel and Joseph, for your presentation. And see you in the general room.